Good afternoon, everyone, and thank you so much for joining us for our latest installment of EMS Focus, a collaborative federal webinar series. My name is Noah Smith, and I'm a project manager with the Office of Emergency Medical Services at NHTSA, the National Highway Traffic Safety Administration. And together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for EMS across the country. And the projects we undertake and the resulting resources for that community help to plan for system improvements, measure the health of EMS systems nationwide, and deliver the data that EMS leaders need to advance their individual organizations. And another role of the Office of EMS is to educate the EMS community on new innovations, processes, and technologies that can help provide better and more efficient patient care. So this free webinar series is a unique opportunity for federal EMS agencies to share information with the EMS community in a manner that's more personal and less time-consuming than going to conferences, but really offers the opportunity to interact and to ask questions, certainly more than a newsletter or an article could do. So EMS Focus conducts webinars on issues that are important to the community and provides you with timely information on what federal agencies are doing about them. Just as a reminder, today's webinar is being recorded and will be archived on ems.gov for future viewing and listening. And of course, more information on all the past EMS Focus webinars can be found on ems.gov. So today, NHTSA's Office of EMS is pleased to have an expert panel to discuss the EMS agenda for the future and how it has influenced the last 20 years of emergency medical services. So 2 decades ago, members of the EMS community came together to describe a vision for the future of EMS systems. And the resulting document was the 1996 EMS Agenda for the Future. That vision has helped to shape our industry and our profession as we know it today. That's thanks to the motivation and the planning and the commitment of the individuals and organizations who contributed to its development. As we all know, the healthcare landscape is changing rapidly, right? And EMS is facing many challenges. Some are new and some are not so new, from the threat of terrorism to the burden of chronic illness. And innovative ideas from telemedicine to community health programs and mobile-related health care are being implemented across the country, but there may not be a clear idea of what the EMS system of the future will necessarily look like. And so as we celebrate the 20th anniversary of the Agenda for the Future, we are also beginning the process to bring the EMS community together to look to the future once again, to continue to advance EMS systems in a way that provides the highest level of evidence-based care to every patient and every community we serve. Before we get started, I just want to take a moment to wish everyone on this call a very happy EMS Week. As you know, EMS Week is a great opportunity to recognize the work and dedication of EMS providers across the country, the work that you all do every day to ensure the safety of our nation's communities does not go unnoticed. And we at the Office of EMS and at NHTSA very much appreciate and recognize your dedication and your commitment, and we thank you. And along with the start of EMS Week, today is also the launch of a refreshed website for the Office of EMS at NHTSA and for our federal partners, which we're very excited to share with you. You'll hopefully find it easier to find resources, to hear about latest news from our office and from our partners across government. So after this webinar, of course, I encourage you to go check it out at ems.gov, your home for federal resources on emergency medical services. Today, we are discussing the EMS Agenda for the Future. Originally written in 1996, the agenda helped shape the last 2 decades of EMS. And so we're excited to be kicking off our effort, of course, to develop and revise a new agenda. And we'll tell you a little bit about how you can be a part of that project and why your input is so critical to that process. Also on today's call, we're going to reflect on what EMS was like 20 years ago when the EMS community decided to get together and write the original agenda, and why now is the right time to set forth a new vision for EMS for the next 2 decades. We'll be joined by some of the original authors as well as one of our federal partners, to talk about the EMS profession, what we've accomplished since 1996, and I think what we may still have left to do. And as always, during these EMS-focused webinars, each of you, our attendees, are encouraged to submit questions using the questions box on the webinar platform during any point in the conversation. and we will address those questions during our Q&A at the end of the presentation. So today's panel is comprised of EMS experts who have each played a role in bringing the industry together towards a vision for our nation's EMS systems. Gam Wijetunge is an EMS specialist and colleague of mine in the Office of EMS, where he specializes in efforts related to homeland security and preparedness, workforce issues, and pandemic flu planning. He's also the president of the Wheaton Volunteer Rescue Squad in Montgomery County, Maryland, where he served as a paramedic for over 20 years. Dan Manz's career in EMS has spanned more than 4 decades. He is the executive director of Essex Rescue in Vermont, and prior to that was the Vermont State EMS director for over 25 years. He's been actively involved in several national EMS organizations, including serving as a board member for the National Registry of EMTs and the president of the National Association of State EMS Officials. In 1996, he co-chaired the EMS Agenda for the Future Steering Committee. Dr. Beth Edgerton is the director of the Division of Child and Adolescent and Family Health at the Maternal Child Health Bureau for the Health Resources and Services Administration, which is part of the U.S. Department of Health and Human Services. And she also represents HRSA on the Federal Interagency Committee on Emergency Medical Services, or FICEMS. The Division of Child, Adolescent, and Family Health houses the EMS for Children and Injury Prevention programs, which she previously led as branch chief. And as a clinician, educator, and administrator, Dr. Edgerton has worked in the fields of pediatric EMS, injury prevention, and clinical preventative services throughout her career. Dr. Ted Delbridge was the primary investigator for the 1996 EMS Agenda for the Future and its subsequent implementation guide. He's currently a distinguished professor and chair of the Department of Emergency Medicine at East Carolina University and vice president of emergency services at Vidant Medical Center in Greenville, North Carolina. Dr. Delbridge is past president of the National Association of EMS Physicians and currently a member of the North Carolina EMS Advisory Council. I'm Noah Smith with the Office of EMS. I'll be serving as your moderator. And with that, I'm very happy to introduce our first speaker, Gam Wijetunge. Gam.
Thank you for that introduction, Noah. Hello, everyone, and good afternoon. So today I'll be speaking about a few things. Next slide. Roughly 2 years ago, the National EMS Advisory Council, or NEMSAC as you may know it, was considering whether or not to revise the EMS Agenda for the Future. Now, NEMSAC is a nationally recognized council of EMS representatives and consumers authorized by Congress to advise both NHTSA and the Federal Interagency Committee on EMS, or FICEMS, on EMS-related issues. So NEMSAC felt a new agenda was needed to address new and important issues that are altering the mission of EMS but have not yet been integrated into a coordinated vision for our industry. Now, specifically, NEMSAC recommended that, 1, a major revision of the EMS Agenda for the Future should be undertaken as soon as possible. 2, the revision process should be guided by an external entity, not NEMSAC, that will ensure a consensus and data-driven process with broad stakeholder representation. And 3, the goal should be to replicate the process used to develop the original EMS Agenda for the Future, published in 1996. And roughly a few months later after this, the Federal Interagency Committee on EMS, FICEMS, which brings together federal officials from the many agencies that support EMS, unanimously approved a motion to move forward with a new agenda for the future, with a focus on data-driven approaches to future improvements. Next slide. So in light of this, NHTSA and FICEMS are both committed to an open, collaborative process to create a new EMS agenda for the future. The first step in this was to announce a request for information, or RFI, and this RFI seeks comments and input from everyone with an interest in the future of EMS, including EMS field providers, supervisors and chiefs, researchers and educators, regulators at state, local, and federal levels, and patients and members of the community. Now, if you click on the link here on the screen, you'll find instructions on how to submit your thoughts and suggestions, including more background on the project and a list of specific questions that you can answer. You'll notice that these questions not only ask for input on the future of EMS and what issues should be addressed in the new agenda for the future, but also for input on the process that should be used to create the new agenda. You still have about 6 weeks to submit your input, so follow the link at the end of this webinar and be a part of this important effort to create a shared vision for the future of EMS. And we'll share the link again at the end of the webinar. Now I'd like to hand things over to our next speaker, my friend and colleague, Dan Mans. Dan.
Dan, thank you very much, and happy EMS week to everybody on this webinar. We can go on to the next slide. So I do think as you contemplate this idea of updating, creating a new agenda for the future in 2016, it probably is worth going back to the time when this original EMS agenda was first developed. And we were at a National Association of State EMS Directors meeting out in Breckenridge, Colorado. I think it was 1994 or 1995. And this whole thing kind of got started with a after-dinner conversation about a very simple question. We were sitting around saying, if we knew 30 years ago what we know today, would we have built EMS systems that look exactly like what we have right now? And I think it was not hard to see that everybody said, well, no, we probably would have taken some things in somewhat different directions. We were liberally using the word system for describing our state EMS structures and other ways that we did things in EMS. But in reality, there was a lot about what we were doing that wasn't particularly systematic. So it was an interesting conversation one evening, but after I got back from Breckenridge to Vermont, I got a call from Dr. Bob Suter from NAEMSP at the time. He said, hey, Dan, why don't we go talk to the folks at NHTSA and see if we could get some kind of a formal initiative going to have a national dialogue on that question we were discussing out in Colorado. And he said, why was I along for this ride? Well, he felt like NHTSA paid attention to state EMS directors, and he wanted to see if our association could help market the idea to the person who was then the NHTSA chief, EMS Chief Sue Ryan. So next thing I know, we're standing in Sue Ryan's office trying to explain this idea, and she listened very attentively but said, look, I haven't got any money to help support such a thing, and well, I'll hang on to the idea, and maybe we can think about it in a future year. So Bob and I went home. Not a lot of action at that point. A year or so later, NHTSA's got a new head, Dr. Rick Martinez, and Jeff Michaels is the new NHTSA EMS chief. And I think Dr. Martinez said to Jeff at some point, hey, Jeff, where are we going with this EMS thing? And how is NHTSA going to help EMS in the country get wherever it is we're going? So I think Jeff, who didn't really come from a substantive EMS background, reached in the file drawer, found this little sketch that Bob Suter and I had brought down to Sue Ryan, pulled it out, showed it to Dr. Martinez, and it was Dr. Martinez, I believe, who said, yeah, like, this is exactly what we need. Like, let's figure out how to help make this thing happen. So go on to the next slide. So we put together a steering committee that are the people you see on this slide. It was an interesting group of physicians, state EMS leaders, educators, nurses, fire professionals, private and public policy type interests. It really was actually Ted Delbridge who kind of in the end took pen to paper and captured the ideas that this group was generating. And I don't think any of us who were involved in this at the time had much of an idea how influential this project was going to become in steering the future direction of EMS in the United States. And as you look at these names, some of these people you may know, some of these people you may have heard of before, I don't know. It's easy to think these were really high-powered, ivory tower, experts. These were just regular folks working in EMS like everybody else. They had some experience, they had some ideas, they had some passion for the subject, but at the end of the day, these were all just sort of involved people who said, sure, I'd like to play a role in steering where EMS goes into the future. So you can go on to the next slide. It's interesting to ask, did this agenda achieve anything? 20 years later, what do we look back on and say is different today because we had the EMS agenda? My answer would be, I think a lot of things are different today because of this agenda. And the one example I'll just use to illustrate that today is in EMS education. If you go back to the late 1960s, there was nothing. There were no EMS systems. Nobody'd heard of an EMT yet. We didn't have any of those people around. And states were looking for a way to figure out how do you prepare people to do this job of working on an ambulance. NHTSA at the time built a national standard curriculum for training EMTs, another one for training paramedics. But those things quickly ran into problems that every time a new skill would come along, every time a new intervention was wanted to be added, you had to go back and revise the whole national standard curriculum. And so the agenda gave us a chance to say, wait a minute, EMS education, we're training a health professional here. We ought to be paralleling the way that other health professionals are developed, and we don't see any other health profession that writes a new curriculum every time they want to change something that the person does. So we envisioned a new system. The agenda led to a very specific education agenda for the future, a systems approach. We managed to get national scopes of practice established. The national standard curricula went away, migrated to education standards. We now have nearly uniform consensus among the states on use of national certification testing for qualifications of personnel practicing as EMTs and paramedics. And then the national accreditation of paramedic programs was implemented largely as a way of assuring the quality of the educational programs that our people go to. And I think this is but one example of how a component of EMS education, moved from a non-system to one that much more closely parallels other allied health disciplines. So we're 20 years down the road now. FICOMS and NHTSA and the National EMS Advisory Committee are all together calling for an update to the agenda. I think the question now is, knowing what we know today, where do we need to go in the next 20 years? And I think we stand at the juncture where there's an incredible opportunity for all of us again to kind of come together in the nation and guide the future of our profession. Thank you.
Thank you so much, Dan, for that incredible perspective. I know I have a lot of questions for you about where the profession was 20 years ago and what some of those conversations were like. And I encourage our attendees, as they're listening, to use that questions box and to type in questions that we will facilitate a conversation about later in the webinar. So now I'm very proud to introduce our next speaker, one of our closest federal partners and a friend of mine, Dr. Beth Edgerton from the Health Resources and Services Administration at the Department of Health and Human Services. Beth is going to speak on one of the topics that was covered in the agenda, and is very near and dear to her and to us, which is evidence-based care. Dr. Edgerton.
Thank you, Noah. And again, thank you for all those on the webinar today. I have the lucky privilege of being able to reflect over the last 20 years and really highlight some of the concrete examples of what we have accomplished over time. Dan Mans has really given a nice perspective of how the EMS agenda set the framework for training the professionals and really codifying EMS care as a profession. And I'm going to try to put my arms around the care that's delivered and all of the elements that are involved. Next slide, please. So again, just to highlight some of the key questions that were put forward in the EMS agenda 20 years ago around clinical care was to commit to a common definition of what constitutes baseline community care. Already there was a vision that we needed to have a foundation or a standard expectation of what care is provided. Ensuring that new care techniques and technology were only implemented after they were shown to be effective. So how do we gather that shared knowledge from the field and science to know what is the best care for patients, again, with an evolving complexity of what we provide in the field? To enhance the quality of published EMS research. Again, 20 years ago, what was available in the literature was very limited, and I hope to show you how far we've come with that in the last 2 decades. And finally, to really understand that EMS needs to partner with others, so not only between other EMS systems, that they cannot necessarily just be a solo entity into themselves, but their collaboration with medical schools, other academic institutions, and private foundations to really develop a shared competency of what all can bring to the table to ensure the best clinical care is delivered to the patient, because at the end of the day, that's really where our focus is. Next slide, please. This schematic you'll see twice in this presentation, just sharing to you of how well it captures the complexity of creating a system for the future. What I want to highlight on this diagram here is on the top one, on the top of the box there, you see all the diverse populations EMS has to serve. So not only are we serving the obstetric, the pediatric, the geriatric, but also really an appreciation of the broad number of clinical topics that we care for and probably weren't even imagined 20 years ago that EMS providers would be faced with in the field. As we look at the face of the box, we really see the systems that support this community care, and that even once we've decided what the best clinical care is from the literature and the review of the literature and development of guidelines, we see all of those that are involved, that ensuring those that deliver the care have what they need, from the education, the leadership of the medical directors, again, the training of those providers in the field. And then finally, on the right side of the face of this box, we see all the systems that support this community of care. Again, EMS is not isolated, but it's really integrated in a continuum. And with our changing healthcare system and focusing on population health, I think this becomes even more important as we move forward. So the main point of this is to understand that it's a complexity of integrated systems. And even though today I'm just focusing on a few, they all really are based on the other components that are present in the system. And as we move forward on that next version of the EMS agenda, we really need to understand the interrelatedness of all of the elements. Next slide, please. So just as Dan had mentioned that the EMS agenda for the future provided a framework or scaffolding for education of the profession, we've had the same accomplishment around developing the best science for the field. And this started with NHTSA's framework for evidence-based guidelines that was developed a few years ago that really took the scientific process of reviewing the literature and science and applied it in what's called the grade methodology that really allows one to take science and then bring in local input and adaptation while maintaining the integrity of best practices, but making it applicable and operationalizable at the local level. And so what you see here are those first publications that first identified the framework and then really test the concept to see, could we take a EMS topic such as pediatric pre-hospital seizure management and adopt this framework and see if it could be taken up by the community. And so again, we had success in that in developing a scaffolding of how we take new information, we make it attainable at the local level, and we're able to implement that. And now we fast forward to actually having the established pre-hospital guidelines consortium led by Dr. Christian Martin-Gill out of the NAEMSP organization. And again, this is a consortium similar to the American Heart that really is being a leader for EMS guidelines and awareness of what's going on in the field so that we keep that standard of care out there, that we really have that knowledge generation. Next slide, please. And as you know, there can be a disconnect that we can have the knowledge out there or the best practices, but how we get that to the field and understand those elements of implementation are another critical part to having that standardized community of care provided. And so what we have here is the initiative led by the National Association of EMS, NASEMSO, and the medical directors who put together a repository of the EMS clinical guidelines. And what is ideal here is it provides the repository of the information that's available and had the foresight to include and embed in these guidelines metrics that local EMS agencies could use to link with the NEMSA's database to really see how are the outcomes and variation of care occurring. So not only are we implementing the best practices, we're constantly feeding the system to see if our training is appropriate, if our resources are available, and whether we're making an impact. So again, this sets the foundation for EMS agencies at the local, regional, or state level to evaluate their compliance with these best practices and the associated outcomes. Our next challenge in the next few decades as we develop the next EMS agenda is to really ensure that there is standard utilization and evaluation of these guidelines as we move forward. Next slide, please. And as we talked about, it's the real challenge is often we have the repository of the guidelines, they're available, and now implementing them at the local level. And with the leadership of one of our grantees at EMS for Children, we had Dr. Manish Shah take on a project for regional implementation of EMS evidence-based guidelines. And this really shows that integration that we talked about into the community. It involves the leadership of the EMS directors, as Dan mentioned, that is essential. It champions the EMS medical directors who are at the interface of those in the field providing care. It brought together the EMSC state partnership grantees since the focus on this effort was pediatric population. It integrated the EMS training and education facilitators. So how are we training our providers in these best practices? And then finally, our EMS data managers to, again, monitor and gather the information. And this really serves, again, as a laboratory or case example to see if can we roll this out at a regional level. So we have 6 northeastern states adopting the same pediatric evidence-based guidelines, doing the same training, using the same metrics, to see if we can really ensure that consistent baseline of community care. And hopefully this will serve as a model for other rollouts of important clinical care that we can really standardize care across the United States. Next slide, please. And now we kind of come full circle in this process, that ensuring that we are really discovering and generating new knowledge to continue to feed the field of what is needed in best practices. And again, since 1996, we've really advanced the field of EMS research. I highlight a few of these milestones. One up in the upper left-hand corner is the EMS for Children's Pediatric Emergency Care Applied Research Network. In 2000, there was a realization that there was very little information on pediatric acute care and what to do, so this network was established. Currently exists of 18 emergency departments across the United States that captures over 1 million pediatric emergency department visits. And this fall, the network added 9 EMS agencies. So that, again, captures over 65,000 pediatric calls. And again, the other exciting piece is these research entities are really focusing on how to use their state NEMSIS data to identify gaps in knowledge and the future research agenda around pediatric pre-hospital emergency care. And then you also see that we had in this time the creation of the Office of Emergency Care Research with Dr. Jeremy Brown's leadership at NIH. Again, emergency medical services is really a setting. We cover all types of clinical entities, so we don't fit into one institute at National Institute of Health, so it's nice to have his coordination and championship. And again, in the upcoming year, a creation of a new emergency care research network that really brings together federal agencies of NIH and the Department of Defense with academic facilities, modeling off of the PCARN model that EMSC has used, and expanding our look at clinical questions to populations and clinical conditions that we, again, see as the need of the community, of whether that be stroke or whether that's cardiac issues, things of that sort. In summary, I really want to say that we have established the key foundations and scaffolding to establish a baseline of a community of care. I think our reach in the next version of the EMS agenda is to ensure that we have standard uptake throughout the nation, that we're consistently assessing our care. We know we have the resources that are available for EMS agencies. We have metrics that are attributable to whether we're providing the optimal care. And now we really need to continue to engage state and local leadership to evaluate this process and provide feedback of where we need to go in the future. Again, we have the best practices, as we can see, with cardiac care, stroke, trauma, and pediatric care. And again, EMS Research is now an established field, and it has collaboration across many sectors of care. And I think the most important thing is that EMS does not stand alone anywhere. It's now really being incorporated as a sector of healthcare and in that continuum of care as we move forward. Thank you.
Thank you so much, Dr. Edgerton, for that incredible perspective on evidence-based care over the last 20 years. And just as you were presenting, I saw some questions coming in about pediatric emergency care, so we'll be sure to get to those in the Q&A section at the end of our webinar. Beth, you also mentioned how some of our key challenges in the future, right, as we sort of start to frame what the revision of the agenda for the future is going to look like, some of those key challenges may not be about developing these big national programs, but about really ensuring the consistent and sustainable implementation at the local level of those improvement tools. And I really couldn't agree with you more. I'm really excited to engage in a conversation with the EMS community about how to achieve that goal. I think without a doubt, you mentioned the work of the Pegasus group that's going on in the Northeast to implement evidence-based guidelines. That's an incredible model for achieving that goal. So moving right along, I'm really honored to introduce our final speaker of today's webinar, who's Dr. Ted Delbridge. He was the primary author of the 1996 EMS Agenda for the Future and its subsequent implementation guide. He's currently a distinguished professor and chair of the Department of Emergency Medicine at East Carolina University. And we'll throw it over to Ted.
Well, thanks very much, and it's an honor to be here, and it's especially cool that it's EMS Week, and I'll echo Dan and wish everybody a happy EMS Week. Dr. Edgerton did an awesome job of paving the way about much of what I hope to talk about. If you can go to the next slide. So I want to talk about this idea of integrated care and also evaluation, and a couple of things that the EMS Agenda for the Future commented on or recommended was that we ought to expand the role of EMS in public health, that we ought to be more integrated with other healthcare providers and various networks, that we ought to be more sophisticated in developing integrated information systems, especially with other healthcare providers and public safety agencies and various community resources, all of whom are dedicated to improving the health of the communities we live in. That we ought to be looking to evaluate the effects of EMS for multiple medical conditions, and that we ought to determine EMS's effects for multiple outcome categories. Next slide. reflect for a moment that in the early 1990s, when this was all being contemplated as a worthy project, it had been over 25 years since the 1966 white paper, Accidental Death and Disability, the Neglected Disease of Modern Society, and how it really compelled or propelled the development of emergency medical services systems in the country. But not a lot had been done to assess whether we were going in the right direction. And the group that was assembled, the 11 steering committee members, thought about this like you might think of a timeline or going on a vacation. And you go so far, and then you stop and you look and you say, are we still going where we want to be going? Are we going in the right direction? Are we making the best time? And that's sort of, I think, what Dan was talking about when he said if we knew now if we knew 30 years ago what we knew now, would we have taken things into this particular direction? And at the time in the early 1990s, just like today, there were all kinds of discussions going on, questions that were sort of mired in the details of the work. And what we recognized was that EMS across the country was really quite variable. And as Dr. Edgerton said, there had been various uptake in all kinds of different ways. And so when anybody was talking about EMS, as the saying goes, when you've seen one EMS system or one of anything, you've seen exactly one. And we thought we needed to be very broad and make recommendations or think about a future that could appeal to anyone, essentially. And we tried to steer clear of the minutia detail of the day and think in very broad strokes. And one of those broad strokes was how we consider EMS to be embedded in the community. And in many places, what had been contemplated in the initial development of EMS was to get the person off the side of the highway and take them to an emergency department. And across the United States, that's how EMS was perceived, and maybe still is in some places, perceived today. It's a conduit to care. And we began to consider EMS not as a conduit to various care. On this diagram could be a trauma patient, could be somebody with a cardiac problem or a child, but not as just a dotted line drawn from the center of the population out to wherever that care existed, but we considered EMS to be actually part of that. And that was the whole notion of integration. Next slide, please. And Dr. Edgerton already gave a super orientation to this. I'll talk about it a little bit. If you have ever read the Agenda for the Future, there's a section in there that talks about how the whole thing was made. So there was a steering committee of 11 people, and we met over the course of a year in 1995, a couple of different ways and times, and began to solicit feedback. This was conceptualized at the third meeting of the steering committee in a really lovely place. But after we had started to get feedback from people that we were sending our draft documents out to, over the course of time, we sent drafts to 500 individuals in various organizations, and those organizations would send it out to more individuals. And so we got tons of feedback back. And we began to think about what is it we were sort of talking about. And so as Dr. Edgerton described, that the top of this cube represents all the various kinds of patients you might encounter. And EMS, as it turns out, within the healthcare system is one element of healthcare that encounters the entirety of the population. Doesn't matter how old or young you are, doesn't matter whether you're hurt or sick, the EMS folks are seeing it all. I'll stop for a second and point out that there are other little cubes on this diagram. The little cubes might represent the criminal justice system or our system of finance or something like that. And so healthcare is like one of these things that society sort of creates for itself to manage a particular issue or problem or concern. The front of the cube became what we described as 14 attributes, not of just EMS, but as Dr. Edgerton pointed out, of any aspect of healthcare. That we assessed that every aspect of healthcare had to have these 14 things in order for it to function. And the side of the cube represents this continuum of healthcare. To the far left is public health, and to the far right is vocational rehabilitation, or getting the person back to work or back into school or back into being a productive member of society. And although it looks very segmented and there's like partitions between each piece, really these things blend. And EMS, or out-of-hospital care, really is part of this continuum of healthcare and has to be integrated with the rest of the system in order for in order for things to work for the community in which we serve. So each one of these aspects of the healthcare system is entirely interested in improving the health of the community, and EMS, likewise, in that role, has connections to all of them, had to have all of these 14 attributes, and had to be prepared to deal with the entirety of the population across the top of the slide. So we began to think of ways in which that could occur. And so back to the first slide in my little section here, talking about better integration with public health. We recognize that EMS providers are some of the only healthcare providers that are routinely invited into people's homes, that see the way the population lives, what may be their risk factors for disease or illness or injury, and being able to mitigate some of those things. We collect tons of data, tons of information, but unfortunately oftentimes it stops with us, and it doesn't get shared very much with other agencies or healthcare providers that are in the position to influence people's health outcomes in really positive ways. Next slide. And we began to think also about this whole idea of how it is we evaluate the work we're doing. So we know we collect a lot of data. Hopefully we turn that data into information. So information essentially being data you can use to do something. And then there are the two ovals, if you will. One's research. So not necessarily everybody in the whole entire world is going to be engaged in research, where you ask new questions, you use the information that you got to enhance your knowledge, and you disseminate that all over so that everybody gets to know. And you're studying efficacy. Do things work in the most controlled environment? Effectiveness, do they work out in the real world? And cost effectiveness, meaning, is the bang worth the buck kind of thing. But we were thinking a lot about evaluation at the same time, where everybody needs to be involved, where we're looking at structures. So how's the EMS system put together in your particular community, or processes? What are the kinds of things you're doing? We measure a lot of stuff. Do we give aspirin to people who are having chest pain? Do we give pain medicine to people who have pain? Do we get there 90% of the time within 10 minutes or 8 minutes or whatever your number is? But the real question we wanted to look toward was, how do we measure outcomes? How do we know that the work we're doing is the right work for the communities that we're in? And evaluation is something that we all ought to be doing all the time, and we ought to be evaluating all those things, structures, processes, and outcomes. We're looking to make system changes. We use the information that we got to see if we had a positive effect from the things that we changed, and then we can make more changes. And oftentimes there's community input, and this is something that's essential for everybody to be doing. It's not necessarily disseminated to the rest of the world. It's information used internally to make us better. We've gotten lots of traction on this, and not nearly as much as we would like, meaning things like NEMSIS have helped us organize our information so that we can use that information to assess how we're doing. There are things like the CARES registry, which has helped us determine how we as a community are doing with regard to cardiac arrest resuscitation, for example. We have developed, in some cases, more local or state-wide registries of information, or our information systems are able to feed us back information with regard to how we're performing for ST elevation MI or stroke or all those kinds of things. And so we're getting better, but we have a lot more to do, and a lot more that to do has to do with the ability for us to integrate our information system with information systems from other healthcare providers, for example, who take care of our patients downstream, so that we know whether we're making a difference in taking care of people with ST elevation MIs, or whether we're making a difference in stroke care, whether the things that we're doing are the right things, or whether we should be doing something different entirely. I'll backtrack and talk about that for a second in terms of integration. A long time ago, we were the conduit. We were the take the person from the side of the road or from their house to care. And now, as health systems have become more sophisticated in thinking about the systematized or protocolized care of patients with particular problems, they're looking to EMS to be engaged in those things. So they're looking for EMS not just to be the transportation mode for a patient with an ST elevation MI, but the time of care begins when EMS encounters the patient. And so what happens in the interval between then and the time the patient arrives at a hospital is critical in evaluating the process of taking care of the patient and hopefully improving their outcome. And the same is true of stroke networks, just as it's been for trauma for quite some time. So we've made a lot of progress. We have a lot of progress to go. I think that part of the success of the EMS agenda for the future was in evaluating things on a more global perspective as opposed to tackling the minutia detail of the day. I will finish with a quick vignette, and that is, I told you we, along the way, collected a lot of information from our peers. I mean, we sought lots of input. The steering committee considered every single written comment and would discuss it at length. Part of the process included a blue ribbon conference that occurred in Virginia in December of 1995, where we invited all kinds of people to come, and they heard presentations, and they broke up into focus groups talking about very specific aspects of the agenda for the future. And what was very interesting to see is when you elevated the discussion, I'll think of it in terms of elevation, when we elevated the discussion and came out of the minutia and talked in global terms, and at the time we were already on to these 14 attributes and thinking about them, that is where the level of conversation just elevated, and people's level of participation took on a whole new dimension. And some of the same factors that would have been otherwise down in the minutia sort of rose up and thought about things in a way more global sense, which I think is how we got to other agendas occurring and thinking in bigger terms than just the details that affect us every day. That's my spiel. Thank you for the opportunity.
Thank you so much, Dr. Delbridge. We really, really appreciate it. And just as I think Dr. Edgerton had done, you did a fantastic job of pointing us and reminding us of some of the incredible successes that our profession has had over the last 20 years, but also where we have a lot of room to grow and work still, where some of the foundational elements may be in place, but that doesn't mean that we're using them to their full potential, and that doesn't mean that everyone and every system in our country has that same level of implementation. And so to me, that just means that this conversation is so important that the time is absolutely right. Speaking of timing, let me congratulate all of our speakers for sticking to their timeline so that we can have enough time for all of you to ask questions and to engage in some discussion here today. We've had a lot of great questions come in. We're going to be able to get to some of them, but not all of them. And our commitment, as usual, is to post the questions that we don't get to online and to provide some level of answers for you on ems.gov after the webinar. So our first question is about some things that were noticeably not in the 1996 agenda. And so the original agenda didn't mention a lot about preparedness issues, about terrorism, about emerging infectious diseases. And I may ask Dan for his perspective on why some of those were left out. Was it because they just really weren't being discussed at the time? Was there a conscious decision to not address those, or was there some other reason?
No, are you able to hear me okay now?
Yes, I can, Dan.
Okay, good. So, no, I think looking back on it, it was a different world back then in 1996. We were sort of pre-9/11, and I don't know that any of us had terrorism as a specific example on our specific radar screens. I think we might have done some things differently had we seen the role and the impact that terrorism was going to have on all of our lives in the country, and I think that's probably one of those changing things in society that needs to be accounted for as we go forward. What technologies do we need to have? How are we going to share information in ways that can better serve to protect people and better serve to take care of people when these unthinkable events sort of happen? So, yeah, I think that one is a great example of something that's just a reflection of the times.
Fantastic. Thank you, Dan. Dr. Delbridge, any perspective on that, or perhaps how we can integrate those issues that weren't necessarily discussed in 1996 into the revision that we're going to be going through in the next year?
So interestingly, nobody's ever accused me of being visionary before. And it didn't happen with this either. I was a very good scribe of people who are really smart. But I would say that the issues of preparedness and responses to things like terrorism, or whether it's a natural disaster, are probably embedded, are suitable for discussion within the attributes that were previously described, meaning all those things are exactly what it takes to be prepared. And probably if events had been 10 years earlier than they were, or the EMS Agenda for the Future was 10 years later than it was, I would say that we probably would have discussed the issues of preparedness and response to disasters, whether they're a terrorism kind of thing or a natural disaster. I think that we would have embedded them as examples within each of the attributes that we described. For all the reasons that Dan, I think, just said, there needs to be an integrated, coordinated response. There has to be adequate communications. There needs to be appropriate medical direction. All those things are relevant. And I think we would have probably called them out more or at all definitively, precisely than we did.
Very good. I really appreciate that. I think we'll move on to our second question. This is a question that I'm going to sort of expand on a little bit. It's from a friend of ours and from a National EMS Advisory Council member named Keith Minoski out of Central Washington University out west. And Keith asks about how we gain parity with other allied health professions. And he asks specifically about elevating the EMS profession through more formalized education and awarding of relevant degrees, which is an incredibly important question. But I want to expand on that a little bit. There we go. I want to expand on that a little bit and ask our panel, beyond education, how do we envision a future where we achieve parity with other allied health professions and other parts of medicine? Indeed, how do we make sure that we are doing so in a way that is not just looking inward, but is looking outward at our partners in healthcare as well? And I'll open that up to the panel. Perhaps beginning with
the panel's thinking.
Okay. Well, Ted, you were the first to respond, so I'm going to put you on the hot seat.
First of all, hello, Keith. Secondly, I think that so parity is an interesting concept. I think that sometimes we feel that EMS is somehow not on parity with some other allied health professionals, and I'm not so sure they don't feel the same way. Not that they don't have parity with EMS, but they don't have parity with each other. I think it's always a relative sort of consideration. And I think the way to elevate EMS within the stature of the rest of healthcare, in addition to being in addition to education being the issue, I think it's a degree of taking responsibility and holding itself accountable. And I think the day is coming. And I'll give a quick example. In my community, the hospital, for example, is looking toward EMS to do some of the same things people are looking at in other parts of the country, and to be more engaged in patients who are discharged from the hospital and helping them follow up and things like that. And they are considering EMS to be hugely responsible, able, and smart people. And so I think there's a greater degree of recognition of the value of EMS. How that conveys into things that are tangible for the actual EMS personnel, pay and things like that, I think those things are more challenging and probably a longer time in coming. But I think it'll come.
I agree, Ted, very much. I think with this is Noah. I think with the advent of truly integrated systems of care, largely through the adoption of health reform activities, and I think with the poking and prodding of a lot of EMS leaders over the last several years, we are beginning to see some of that parity. Of course, Keith Minoski brings up a wonderful point that that's never going to be truly implemented without a re-envisioning, perhaps, of how we are trained, how we're educated, how we're paid, and a variety of other things. And I think that's where the really exciting conversation is going to happen in this Agenda for the Future process. We'll move right along, actually, to our third question. Our third question is on pediatrics, and it comes from Dr. Fulton. And he notes that the last 20 years, the agenda process, and I imagine the EMS for Children program has been incredibly influential in improving the care of some of our most vulnerable population, pediatrics, kids. And so I'm going to direct this next question to Dr. Edgerton. I'm going to ask, what are the challenges in pediatric care that need to be considered during this revision process? What should be at the top of mind for the community?
Thank you, Noah, and thank you, Dr. Fulton. I think our main challenge is what's also similar to the EMS agenda in general is just the consistency across the nation so that we really are innovative and creative for communities that may not have the same resources, whether it's workforce development or resources for training, things of that sort, of rural communities, our volunteer services, that we come up with systems where we can have some standardization of care. I think as any profession develops itself, we really focus on our uniqueness, and I think maybe now we need to reflect on what are the caveats of pediatric care, but really change the perspective from EMS providers that they have the ability to care for children and where are the times they need that consultation, but instead of we're scared of taking the kids, we can take care of them and how can we do our best job. So I think maybe a little change of messaging, a little innovation on how we get best practices to individuals and creativity around our training so that we really can assure no matter where a child lives, it's not a matter that they're penalized for that if the resources aren't available or the information hasn't gotten to those communities that they don't suffer.
Fantastic. Absolutely, Dr. Edgerton. Thank you so much. And in the interest of time, I think I'm going to ask our last question to our panel today. And this is one that is not surprising and that is really encouraging, and it's about reimbursement and financing EMS systems of the future, which is absolutely a critical part of this conversation that we have to engage in. The question is from Steve Tralla from Cambridge Rescue Squad, and he says that the biggest concern I have is regarding reimbursement. I have a lot of programs in development, but financial support is difficult. And his question is the group looking at reimbursement? And Steve, I may take that question and just shift it just slightly and not ask, is the community, when engaging in the agenda for the future revision, looking at reimbursement, but perhaps how do we envision an EMS system through the agenda process where payment reforms are not just possible, but they're probable? Essentially, how are we setting ourselves up for success when it comes to financial support? Is there a conversation we can have in the agenda process for that? So first, I'll just ask, I know Dan Mance, his phone dropped off. Dan, are you back on by chance? Perhaps not. Okay, so I'm going to throw that very tough question to Dr. Delbridge first and then Dr. Edgerton, and then we'll wrap up.
Well, it is absolutely, positively a conversation that needs to be had, and there needs to be opportunity within the process of revising the agenda to have it. It's an incredibly important one. Yes, and up till now, the discussion has always been when it comes down to a practical sense, the answer always has something to do with what is possible, and it's much less about what is probable. I think that the opportunities that have existed so far have been through demonstration kinds of projects and creative investments by, for example, a health system who's interested in capitalizing on EMS's expertise to make something happen for itself. I think that what we had envisioned in the 1990s was that there would come a day when an EMS system was financed, compensated, remunerated, mostly on the basis of its preparedness, because I think as with most things of this nature, the real effort comes in being prepared. It has to do with having the right resources and the right personnel and the right equipment and education and those kinds of things. And what we had envisioned was a time when that would be the basis for compensation and not necessarily where a patient was or was not taken to. And so I think those are real conversations that need a sort of a different level of dialogue than we were able to accomplish in creating the last agenda by people who have influence in making those changes occur.
And no, this is Beth. Just a few added comments. I think we may also, again, need to be a little bit innovative in looking for multiple sources to support our EMS system, because I think we've had healthy conversations over the last 2 decades of the multiple missions that EMS provides, whether it's the public safety net, whether it's preparedness, whether it's acute care and being part of the healthcare sector. So each of those may need to look for different sources of funding. And again, we've advanced from being the conduit, the transporter, to really an integral part into community well-being and also providing healthcare. So we may have to be a little bit more strategic in where that reimbursement comes and how we message that to those that are in charge of reimbursement.
Yeah, I'd echo that. I think that's exactly right.
This is Dan. I agree with all of that as well, and I think the problem we face today in the system is we're still getting paid for the ride to the hospital. That's where most providers are able to access the bulk of their revenues, and I think we gotta sort of move beyond that and figure out how can we demonstrate the value that we are adding to patient outcomes in ways that will enable insurers and others who are paying for those services to see the contributions that EMS makes.
Thank you so much, Dan, and really thank you so much to all of our panel, to Gam from NHTSA, to Beth from HRSA, from Dr. Delbridge, and from Dan. And to all of you for joining us today. I really very much appreciate you taking an hour out of your EMS week to spend with us. And I hope that what we've been able to do here today is to spark your thinking and to spark your interest in this process and really to motivate you to get involved. And don't forget that you can really be a part of creating the new agenda for the future in EMS. You can submit your responses to the request for information that is out right now. It's the link to which is on your screen. And just as a reminder, this is the first step and your first opportunity to get involved as we work together with members of the EMS community, just like you, to create a vision for the future of emergency medical services. I really cannot thank you enough. I wish you a very happy EMS week and a great rest of the day. Thank you all so much.